the Institute of Psychiatry in London. Now he holds his professorship in Dublin. And I should say he's an honorary Canadian, as he spent some time in Canada, but he's in fact an Irishman. Thank you, Declan.
Thank you for the introduction. Thanks for inviting me here today. It's a pleasure to be here again in Turkey. I'm going to talk about ketamine and its role for ketamine in routine clinical practice. And just to get an idea, I mean, how many people here have prescribed ketamine? Just put your hands up. Anybody at all? Nobody, okay. Anybody here taking ketamine for fun? Nobody, excellent. Okay, just to move on, these are my disclosures relevant to this talk. I'm going to talk a bit about ketamine, give you kind of an introduction to ketamine and its role or potential role in treating depression. I'm going to talk about issues of safety, tolerability, and regulation, and then look at how it might be used in clinical practice. So I'm sure many of you know this already, but ketamine is an anesthetic. It's been around since 1970 or so. It works by blocking the NMDA receptor. So it works through the glutamate signaling system within the brain. Ketamine itself is a racemic mixture of R and S ketamine, so left and right version. So they're mirror images of each other. And it's long used in veterinary anesthesia and in situations where you don't want the patient's blood pressure to fall down, as might happen with other anesthetics. So specific uses, especially in hemodynamically unstable patients. But it's a dissociative anesthetic, and this was described very early on in the early 70s as people taking ketamine being disconnected from their environment. So it alters the level of consciousness itself, and is in addition to being an anesthetic, it alters their consciousness and people's perceptions of themselves and their environment. And because of that, it's used for recreational purposes as a sort of party drug or club drug, so Special K, for example. And the most extreme version of this would be the K-hole phenomenon, where the individual taking ketamine is completely flattened out, obtunded, unresponsive to the environment at all, and completely dissociated. And this is a situation that can last for a couple of hours until a person emerges from it. So it's a particularly unpleasant experience. Ketamine itself can be given pretty much any way you can mention. But for the purpose of this talk, I'm going to talk about how it's been used for treating depression, mostly as an intravenous infusion, and in recent years, S-ketamine has become commercially available as a nasal spray called Sprayvato from a drug company called Janssen. So the doses of ketamine required for anesthesia are roughly, let's say, 4 to 5 milligrams per kilogram, given reasonably quickly to put somebody to sleep. About a dose much less than that, 0.5 milligrams per kilogram, given over very slowly over 40 minutes, is what's been typically used in the antidepressant trials over the last 15 years or so. Recreational use for this kind of dissociative effect is somewhere in between those, so it's not putting anesthetizing the individual. Now, interesting enough, the observation was made just over 20 years ago that when ketamine given as a slow infusion, the dose I described, has a very rapid onset antidepressant effect. So we're talking about within hours, peaking within about 24 hours, and lasting perhaps for up to a week with just a single infusion. This was then confirmed about 2006 by Carlos Zarate and colleagues in a relatively small but randomized trial. And initial response rates were reported to be about 70%, which is probably the high thing you might expect with their early results. So this is something that worked really quickly. Think about the monoamine drugs that we all use take weeks to work if they work at all. So here we have something that works really, really quickly and on a different neurotransmitter system. Now, subsequent trials, mostly of single doses, single infusions, takes about 40 minutes for infusion, have, when meta-analyzed this group last year have roughly response rates at 24 hours of about 42%, but remission rates of about 20% at 24 hours. And this diminishes as the week passes. The interesting thing about this is that these effects persist beyond the immediate half-life of ketamine, which is about 2.5 hours. We're talking about effects that last 24 hours or a few days longer. So it does something else downstream of that. The other interesting observation was that ketamine reduces suicidal ideation, suggesting there may be a potential clinical role for ketamine in certain situations. And more recently, trials have been using repeated doses of ketamine, so repeated infusions, say 2 or 3 times a week for a few weeks, and these seem to be reasonably safe and suggest there's some persisting effects over time. Precisely how ketamine mediates its antidepressant effect is not clear. I'm not going to really go through the slide in too much detail, but so I mentioned it blocks the NMDA receptor, but it also can activate the AMPA receptor through its various metabolites, and but these seem to converge on downstream signaling mechanisms through BDNF and mTOR signaling to have, certainly in small animal models, we don't know this for definite humans, have effects on plasticity mechanisms, for example, increased production of postsynaptic density proteins, and at a cellular level, evidence for new spine formation. And all this happening pretty quickly, within the space of a few hours, which is quite remarkable, if you think about it. So, there's been a plethora of trials, mostly smallish studies, to be honest, and in parallel with that, a plethora of systematic reviews and meta-analyses. This is the most recent one to come from the Cochrane group. They updated their 2015 meta-analysis just a couple of months ago, and this is about a 450-page document if you want to have a read of it, but they do make several points. I mean, kind of state the obvious that when compared, say, a comparison like midazolam, there's evidence of benefit for ketamine, 24 hours, but this is gone within a few weeks afterwards. And also the comment about the quality of the evidence here not being more low to moderate level evidence. But a lot of the problems with the trials are to do with some of these issues here. So blinding is a big issue in the trials. Early trials just compared ketamine with saline, so it's pretty obvious if you're getting ketamine or not. Subsequent studies more recently have used an active comparator like midazolam, which is benzodiazepine, has a similar half-life to ketamine, causes some sedating effects and so on, but nothing like really the dissociative effects that happen to people who get ketamine infusions. So I think there are definitely problems with blinding in these trials. Also, what's the best comparator? That's still a problem as well. So this leads to problems with the quality of the studies. Additionally, we've problems, there's limited data really about the long-term use of ketamine. I suppose by long-term use, I'm talking about like using it for, say, several weeks or even months, and what are the longer-term outcomes over months and, say, a year or so when people are take ketamine to treat depression. So we don't really have that level of data yet. This is a Cochrane review as well for S-ketamine, and pretty similar sort of results, really. There's evidence for some benefit at the end of single dose. The more recent trials of S-ketamine in the last few years have used added in S-ketamine, say, to an antidepressant, and have looked at that combination. And interesting enough, on that sort of basis, it's been approved. S-ketamine has been approved by the FDA in the United States. I think it's been approved in Europe, but hasn't been approved by NICE in the UK, and certainly in Ireland it's still under review. NICE's view that this was not a cost-effective treatment, but it's actually going under a second review at the moment, which is taking some time. So that's the sort of level of evidence we have at the moment, I suppose, in terms of systematic reviews and meta-analysis. What probably helped S-ketamine, the nasal spray version of it, get approved in the United States, and its approval was for treatments for resistant depression, whatever that might mean to you, is some benefits in relapse prevention. Lower relapse rate in those who were continued the esketamine nasal spray compared to those who didn't. So that perhaps combination kind of got it over the line, certainly in the USA. And I mentioned suicidal ideation. Again, there's pretty good meta-analytic evidence for the anti-suicidal effect of ketamine. Again, it lasts, for a short period of time in, say, an emergency room situation. But beyond that, we don't have great data. So about safety and tolerability. This slide is from a study by Colleen Liu and colleagues published in Lancet Psychiatry a few years ago. And basically, they kind of summarized physical side effects of ketamine. So a particular note I put the star beside them, its effects upon blood pressure. So you might have mentioned that a benefit of ketamine as an anesthetic is that it doesn't reduce blood pressure but can raise it. But from a psychiatry point of view, that's not necessarily a good thing. So when we have patients in the clinic having ketamine, we need to do quite detailed monitoring during the infusion and for up to about 2 hours afterwards. So we look at their blood pressure, ECG, heart rate, and pulse oximetry, and so on. And we certainly see patients whose blood pressure goes up, and we have to maybe give them a beta blocker to bring it back down to normal. And in clinical trials, this is reported about 7-10% of patients. But otherwise, it seems to be pretty reasonably tolerated, I'd have to say. With regards to the dissociative side effects of ketamine, we have an interesting phenomenon that these are more apparent in the first infusion sessions. This is data from our group in Dublin. This is midazolam, the orange line, blue is ketamine. So the higher this number here is, the more dissociative side effects people get. You can see that second infusion dissociation effects drop, pretty much normalized at third and fourth session. Quite why this happens isn't clear, but this has been well reproduced in other groups as well. But the big physical health side effect that we have a worry about is this phenomenon of ketamine bladder, reported relatively recently. And these are people who get this problem who've been taking ketamine for recreational purposes, say 2 or 3 times a week for actually 2 to 3 years. So the chronic users of ketamine. What happens to get a inflammatory cystitis, which is erosive, so it destroys the lining of the bladder. You can see this poor person here has calcified bladder wall, and once you reach that stage, the treatment is cystectomy, remove the bladder. So it's a pretty unpleasant thing. This is very erosive inside the bladder. You can see here, just totally destroyed. That's irreversible. So this brings the issue of like, well, how long should people be taking ketamine? This is why we're interested in the longer-term side effects of the treatment. I think in regulated clinical use, this is probably not a major problem, but something we do carefully monitor these sort of urinary symptoms. So what about ketamine in routine clinical practice? An issue that's been raised pretty early on is the kind of unregulated use of ketamine and sort of almost exponential rise in ketamine providers. People are just setting up ketamine clinics. This is data from the United States from a few years ago. And it is a concern to I think, the medical community. A lot of people seem to be just setting up these clinics out of the blue, really. These are some advertisements I just got just about last week on the internet. If you search for it, you'll find it pretty easily. This is from a clinic in New York. This is one from Virginia, just a few hundred miles south. And these are in-person clinics, so you could sign up, go there, get some sort of medical or psychiatric review, and attend in this lovely nice room here for your infusions, and then monitor you, which is fair enough, I suppose. At least you're being monitored. However, other clinics are perhaps not so robust in their regulatory practice and will mail ketamine to you. You can take it home and see what happens. So it it is a problem, and it's a bit like the Wild West out there in some parts of the world. You get a lot of cowboy operators in this field. So this is a problem that the research community have concerns about. Because of this, we were interested in looking at, well, what sort of information do our patients get about ketamine? So we did a study to look at online news media reports about ketamine as treatment for depression, just before, up to 2017, just before S-ketamine became available, really. And you can see that there was very little up until 2006, not much after that, and then it kind of took off in the last decade or so with a lot of interest. This is news media companies who create their own information online, so larger newspapers, CNN, Wall Street, New York Times, etc. And when we looked at what's in what they're reporting, they're pretty good at reporting, information about ketamine, what's it used for in depression, and has rapid onset. But they're not so good at these items here. They don't say, well, there's actually a lack of evidence comparing ketamine to any other treatment, pretty much, in psychiatry. So we don't know how ketamine compares to standard care. And they tend to ignore issues of regulation and the need for kind of agreed upon standards of guidance for practice and patient safety and monitoring. So even though I would say ketamine is certainly a paradigm shift in the way we think about depression and possibly could treat depression, something that works very quickly, as opposed to having to wait several weeks. And it's certainly providing new insights into the biology of depression and may well be paving the way to other novel drugs for treating depression that perhaps don't have the side effects of ketamine but will have the antidepressant effects. But still a lot of unanswered questions. What's the best way to give it, an infusion or a nasal spray? There's no comparison with standard care. Should you have single or serial? How often should these serial treatments be? How long should they go on for? Can you predict who's going to respond or not in advance? We don't have that level of detailed information about it. Is this a cost-effective treatment? And this is the big problem NICE in the UK had about it. They said this just costs too much. So I would say the cost of ketamine is probably like a single treatment is about the same cost of a, say, ECT session, 600 euros. Okay? You have to pay for all the monitoring and so on. So who would give it? We have an anesthetist giving our ketamine in our clinic, research clinic, I should say. So that makes it expensive. And what about the longer-term benefits and safety? There's also issues of addiction and abuse risk. I think in regulated, sanctioned way, this is not a particularly major problem, I don't think. So just to conclude, we have a study underway to try and address some of these issues, which is a pragmatic randomized trial called KarMA-DEP2 trial. Ketamine is an adjunctive therapy for major depression. And people get twice-weekly ketamine infusions up to 2 per week for 4 weeks, up to 8 sessions, with a 24-week follow-up, 6-month follow-up, looking at the immediate longer-term benefits, but also looking at quality of life and cost-effectiveness, and looking at predictors of response. So I just talked a bit about what ketamine is as a drug, its potential role in depression. I think, does it have a role yet in routine clinical practice? I would say it doesn't. We need more data, long-term data, and exactly the best way to give it. And with that, I'd like to thank you for your attention.
Thank you very much for an excellent talk, Declan. We have time for 1 or 2 questions from the floor. Would anybody like to ask Professor McLaughlin a question? Maybe I'll start. One of the issues is that people have to keep coming back for a top-up, particularly for reduction of suicidal ideation. Any ideas how we can move towards sustained benefit? Some of the psychiatrists I talk to who use ketamine say it's particularly useful for people who are acutely and seriously suicidal, settles them right down, but it doesn't last.
I think it's this benefit for acute suicidality, but not for chronic suicidality. So you can't forget to use the psychological interventions, social interventions, regular pharmacology, and so on. So we don't know. We just don't know how the best way to use this drug is to manage suicide and suicidality in the longer term.
I think if we could, we'd be making if we could get a handle on how that happens, that would be an incredibly useful technology. Any other questions? Yes, please. Yes, at the front. Yes.
Thanks for your great presentation. Does the duration of depression affects the ketamine effectivity, or
So how long the episode of depression was? Well, I would say it probably does, like every other treatment for depression. We know that the longer the chronic depression doesn't really respond so well to other treatment, ECT or antidepressants or other treatments. So it probably does. I don't know the precise data on that offhand. The trials to date have kind of looked at limited populations of people. They tend to be under 65. The criteria for treatment resistance is pretty loose. They're not necessarily very generalizable data.
Thanks.
Thank you very much, Declan. We'll move along to the next presenter. And the next presentation is being given online by Professor Yambo Zhang from the Department of Psychiatry at the University of Alberta. Yambo is a recent recruit, the last 3 years, to the University of Alberta, previously working at the University of Saskatchewan, and is now leading an interventional psychiatry group that integrates many of the new advances, including new approaches to using drugs, including psychedelics. And in the area of cannabis, he was instrumental in reporting to government on issues related to medical use of cannabis and legalization. Today he's going to talk about evidence of risk, benefits, and transcultural issues. So welcome, Yambo. I think we're just waiting to make the connection. Here we are. But we have no volume yet.
Hello? Can you see? Can you hear me?
We can hear you now, thank you.
Okay, wonderful. So yeah, so as a quick disclosure, and I received research support from both university, the government, as well as the industry partners. And but today I'm not, in my conversation, I'm not going to talk about any specific products that from the company that support my research. And I have no strong position of marijuana legalization, even it has been legalized in Canada. So all my view here will just purely from clinician and translational researcher. Yeah. So, and today I hope that we can do a quick introduction to the history and legal status of cannabis. And then we review a really brief psychopharmacology of cannabis. And then to see what's the evidence out in terms of the cannabis, the impact on psychiatric disorders. Yeah, so here you can see this is a very brief history that summarized 6,000 years of interactions between human beings and cannabis. And the green part, you can see that it started from the Eurasia areas and being widely used as herbal medications until the time that when Ottoman Empire, and they decided to put against cannabis, and this has been regarded as the first war on drugs in the world. And since then, cannabis has been considered as harmful products and been banned in multiple places until in 1970s, and it's been banned by the UN. So the black part actually shows the revisit of cannabis since 1975. and to realize there's some medical potentials of using marijuana. And in 2001, Canada became the first country legalized the medical marijuana use. And later on, Uruguay became the first country that's legalized for non-medical use, and Canada followed as a second. And currently, cannabis can be purchased in Canada, just like alcohol and tobacco, and for the recreational use. So with current map by July 21st, there's more and more countries that start to legalize or decriminalize cannabis use, which made cannabis use the biggest substance that's used across the world. So that makes it quite important for us as psychiatrists to understand cannabis and also to recognize the pros and cons of using cannabis legally or illegally. So to understand it, and we have to get to know a little bit about cannabis, how it interacts with our body. And in our own body, we actually have some analog similar as cannabis. We call it endocannabinoid. So which mimic or cannabis plant or the cannabinoids mimic this compound and interact with the inner system and the receptors in the body. So when we talk about cannabis, and primarily we talk about the cannabis sativa, it's a plant which have several hundred different compounds and over 100 of cannabinoid in that plant. And the most studied one include THC and CBD. THC is the one that's responsible for the psychoactive symptoms, and CBD is not. So we can see more than that. There's many other things has been under research and to try to figure out the potential beneficial or the contribution to their medical or medicinal effects. So when cannabis were consumed, it primarily goes through two receptors that medicates their functions. That's called CB1 and CB2 receptors. CB1 is the most abundant receptor that in our brain. It's located on the presynaptic terminals of the neuron. So their function is to modulate the release of other neurotransmitters that's from the presynaptic terminals. So CB2 is different. There's very little in the brain, but primarily in the peripheral part and highly concentrated in the immune organs like a spleen and the macrophage, and you can see all of that are related to immune regulations. So that played a very important role in reducing inflammation and neuropathic pain. So THC, the one that causing the significant psychoactive response, actually is a partial agonist that's at CB1 and CB2 receptors. And CBD is less known, but it's believed that can modulate the activity of CB1 receptor and prevent its activation. So the typical effects of cannabis can be categorized as chronic or acute, and at low and higher dose, they have really different responses. And the physical part and includes the vasodilations and the bronchodilations. And everybody has a different response. And many of my patients told me that even that they were told that cannabis may be helpful for them, but they experienced the highest and the strongest anxiety that they had when they had cannabis. So, but other people said it's only the only thing that can help them with their anxiety or their mental health conditions. So primarily the mental health effects of cannabis, and including euphoria, relaxation, and well-being, which invited the people to continue using it. but also people can show that they become very talkative, disinhibited, and with a distortion of time and space. And to more extreme conditions, it could lead to severe anxiety, panic attacks, and hallucinations or paranoia. It depends on the dose and also the personal experiences that the users. So in terms of the impact of cannabis on mental health, mental disorders, it has been a long and complicated history in the past. And there's increasing evidence to show in some areas that cannabis do have a stronger impact than others. But when we talk about the impacts, we have to really consider the risk-benefit aspect from the products factors, such as what kind of drugs or products compound that's being used, how they use it, by smoking, by using edibles, or by using oils, and how do they use them acutely or they use them chronically, and what amount of they're using, and how frequent they use it, and at what timing, such as did they start early when they were in their teenager years, or they start late and as a pain management when they into their 60s. So also each individual users really have a different features when they responding to cannabis, and also how cannabis can impact their life, such as their age, gender, sex, physical and mental health conditions, and their comorbidities with other medical conditions, what medications they're taking together with cannabis. So it made it extremely complicated, and more research is definitely warranted to help us understand better. So here I'll spend a little bit more time on psychotic disorder because this is the most clear and evidence-based studies here. And anxiety and mood disorders, there are some evidence, but not necessarily giving the best research that we can rely on. In terms of PTSD, I have a colleague here who will do more introductions on PTSD side. So before we talk about that, we should keep in mind that the cannabis in current days are completely different from 1960s when hippies started for peace, not for war, and in California. At that time, it's around 4% of THC that's in the dry compound, the dry, the dry plant. But now it's rapidly increased to nearly 20% in the dry plant, which has been driven by the customers' need, and the growers, legally or illegally, has been modifying the compound, the plant to get high yield of THC, so they can have a better market and a better customer satisfaction from there. But that actually completely changed how the cannabis that plays a role in the physical and the mental health area. And in opposite, and CBD, which being considered as a balanced drug, balanced compound with THC to help to reduce the side effects, dramatically decreased over years. So that makes the current compound, like cannabis compound, way more potent than years ago. And also other way of using it, and also increase the THC levels, such as if they use the condensated oil, or they use the ricin, so that can lead into even 40 to 80% of the concentration. So keep that in mind, because this really changed how they play or interact with our body. So in terms of psychotic disorders, we probably know that acute exposure to cannabis product, especially at a high level, could lead into a brief psychotic episode. And some of those episodes may turn into a more chronic persistent conditions, and even without cannabis in the system. So cannabis impact on psychotic symptoms are quite related to the population who use it. So there's a study that's recently published on JAMA Psychiatry showing that in the high risk of population, those we know that in schizophrenia studies, and the people who not really having a full-blown of psychotic symptoms, but they have some other some other symptoms that predict they're going to have schizophrenia down the road, and they have much higher rate in terms of using cannabis. So this demonstrated the association between the cannabis use and the development of schizophrenia, but does not really tell us whether cannabis that plays a direct role in the development. So another study that's published a year ago and showing that even the patient who just diagnosed with schizophrenia and without even medication treatment, and they have abnormalities in their internal as an endocannabis system, and this abnormalities has an inverse association with symptom severity and can be normalized by the successful treatment. That gave a stronger evidence from causal factors, and see it's not only just cannabis from outside. It already the patient who develops schizophrenia actually have inner vulnerabilities, and it's also associated with the treatment. It is dynamic, can be changed, and by the treatment as well as by the symptoms itself. So back to here is, so cannabis, the role of cannabis in psychotic disorders development and maintenance actually quite related to the dose and age of the use started. And there's a research a few years ago in Sweden showed that if the patient who has more than 50 times use before age of 18, and they have 3 times higher risk of developing schizophrenia by the age of 45. That means even early onset, early time impact from cannabis can lead into a prolonged influence that's 20 years later. So also more continuous use providing a more stronger impact that's on the psychotic symptoms, and also the process of the disease development, such as like relapse rate and hospitalizations, and also more serious symptoms. So that's all published in quite prominent researchers in roles for that 3 years. So, and the more recent one that's published here showing that a daily use and high potent products that's more than 10% of THC actually are the significant risk factors of developing psychotic disorders. And also it can advance the onset of the symptoms and make the onset age much earlier. And it's also increased the psychotic symptoms in the patient who already have like psychotic disorders diagnosis. So that's really helped us to understand it's in this population, and it's very important message to share is do not use any compound, do not use any cannabis, and if they can avoid. So there's some hope that cannabis may provide therapeutic effects, especially the CBD and for psychiatry disorders. And there are several studies provide some promising effects showing that the CBD treatment may benefit schizophrenia patients as a adjunctive therapy, which published like a few years ago on American Journal of Psychiatry. And in the same year, another research group also showing that the CBD treatment can improve the cognitive symptoms and some psychotic symptoms that in the patient with schizophrenia. However, more recently, there's a two systematic review and could not come up with adequate evidence to show that CBD or THC can be used safely and effectively to treat schizophrenia patient. However, this is one of the important area that has been actively explored, and to hope that CBD with a right amount and ratios with THC can provide some beneficial effects to the patient who has psychotic disorders. So in terms of cannabis in other disorders, it's less concrete in terms of their interactions. It's very complicated, but increasing evidence shows that cannabis may have positive associations with risk of depression and suicide ideations in young adults, in female populations, and also the early age onset of cannabis use are more associated with those psychological distress and also suicide ideations. So,
Dr. Zhang, you have 2 minutes left.
Okay, so I'll skip this. So there's no evidence to show that the cannabis can be used as a treatment for depression or anxiety at this stage. So in terms of this, and we really have to say that after the legalization, and we found that cannabis have a major impact on the patient, people in the vulnerable population, like non-white and low education and poor mental health, as well as the poor household incomes. So that means cannabis become another social adverse effects that further splits the society. And also, because even after legalization, that's cannabis, people are seized or arrested by the police, and showing that there's a significant more in the people of colors compared to white in the States as well as in Canada. But the industry itself are dominated by white and male leaders and investors. So this is really showing that this changed the whole picture of how cannabis as a drug that impacts the society. So taking home point is cannabis increases the risk of psychotic disorder, which is very clear, and there's no adequate evidence to support the beneficial effects in mental health treatment so far. The vulnerable populations, especially adolescents, people with mental health or addiction history, and need to be really careful with using it medically or recreationally, and if possible, to reduce or have a low risk of use, including delay the cannabis use age and not using frequently or regularly, and avoid the high potent or high risk cannabis products, and not driving while using cannabis. So that's my presentation here, and any comments and questions, welcome. Thank you.
Thank you very much, Amber, for a very clear and interesting discussion. We have time for one question now. We may have time at the end. Does anybody have a question for Dr. Zhang? No? Okay. Thank you very much, Amber. That's really great. We may have a question. question at the end of the session. Thank you. So we will move on to Dr. Bo Chow. And I believe Dr. Chow has provided a recorded presentation for us. He is an assistant professor in psychiatry at the University of Alberta and an expert on machine learning and big data. He was trained in mathematics in Beijing and computational neuroscience in Boston, and has been a professor of psychiatry for about 3 years now, pursuing advanced machine learning and AI work. So look forward to his presentation, which will roll now. Thank you.
Hello, everyone. My name is Bo Cao. I'm assistant professor and Canada research chair in computational psychiatry at the Department of Psychiatry, Faculty of Medicine and Dentistry at the University of Alberta. Today, I'm going to present 2 of my previous works. One is about predicting treatment response to electroconvulsive therapy in major depressive disorder. And the other one is about the placebo effect in major psychiatric disorders. So we try to predict the treatment response to electroconvulsive therapy using hippocampal subfields and machine learning. So in one of our previous study, we find the hippocampal subfields, they might be affected by the mood episodes. So when we talk about hippocampal subfields, so we usually have multiple regions like the CA1, CA2, 3, and 4. And then we also have the subiculum regions and other regions in hippocampus. So we know hippocampus is a hub for memory, and also it's involved in heavy communication between amygdala, which is just next to hippocampus, and the hippocampus itself. And so it's actually a very plastic region, and it's actually get affected or even damaged by many events of life, and the mood episode might be one of them. So so in this study several years ago, which we published on Molecular Psychiatry, we found in bipolar type 1 and type 2 bipolar disorders, there are multiple hippocampal subfields got smaller volumes compared to the healthy controls. So in that study, we thought, okay, so maybe the manic episode and maybe also the other episodes, relevant to bipolar disorder, might damage the hippocampal subfields. And in that specific study, we didn't find much difference in major depressive disorder compared to healthy people. But in that study, the MDD patients, they were not severe enough compared to the bipolar patients. So we still thought maybe it's a general thing that mood disorder, the episodes in mood disorders, they may cause maybe it's damage, but at least it may cause smaller regions in the hippocampal subfields. And maybe the manic episodes, they have a stronger effect. So it's actually back then we thought, okay, if that is the case, maybe the hippocampus can be a biomarker for the early emergence of certain mood disorders, or it can be a marker for certain treatment response. So this was the motivation that when we did a study on predicting electroconvulsive therapy using hippocampal subfields, but also using machine learning. But before we talk about machine learning, so even just to do an observation of the hippocampal subfields before and after ECT. So I believe everyone here in this conference may be familiar with the ECT already. So it's actually a procedure to induce the seizure. Nowadays, usually during anesthesia. So this ECT therapy is proved to be very effective for several psychiatric disorders, especially for mood disorders. So in this study, we actually collaborate with our partner in China, and they collected some data, before and after ECT for the severe MDD patients. And what we found was that the ECT alone actually will trigger an increased volume for almost all the hippocampal subfields. So especially the CA regions and also the granular cell regions and the molecular layer. So this is what we saw, and then we use the baseline hippocampal subfield volumes and the machine learning algorithm to try to make predictions of the treatment response. So here we collected the Hamilton depression scale before and after ECT treatment, and a decrease. So because the Hamilton depression scale is a scale to measure the severity of the depressive symptoms. So a decrease of the Hamilton D will be an indicator of a symptom improvement. So we use machine learning algorithm to try to make individual predictions here. So each on the left figure, you will see that each dot is an individual patient. So we use cross-validation techniques to make this happen, and we try to predict the amount of the decrease of the Hamilton depression. And so on the figure on the left, you will find the x-axis is the actual Hamilton D decrease, and the y-axis is the predicted Hamilton decrease. And what we found was that using this very simple machine learning algorithm and based on hippocampal subfields at baseline, we can predict the decrease of the Hamilton depression scale for each individual patient in the future, which compared to the baseline, which was the time that they finished the ECT. So we also show on the left figure that this model was accurate for both the remitters and non-remitters. And on the right, we show that based on this algorithm, we try to classify. Actually, we try to predict who will become the remitters or who will become the non-remitters. In the future, compared to the time that they got admitted for ECT treatment. And on the figure on the right shows the what we call the ROC curve, and you can see that it's actually a quite nice model for sensitivity and specificity. So this paper was published on scientific reports. Certain potential markers, it can be like the biomarkers like we show here, derived from brain imaging data, or from other markers like clinical or cognitive or behavior markers, and along with machine learning techniques, so that we can make individualized predictions for treatment response. So the next section, I'm going to talk about the more recent work that we actually perform a study on the placebo effect across major psychiatric disorders. So here we talk about major depressive disorder, MDD, and bipolar disorder, the depressive episodes, and the bipolar disorder manic episodes, and schizophrenia. So we show schizophrenia as CZ in the following slides, and BD depth as BD depression, and the BD man as BD manic. So this is actually there's an ongoing debate about placebo effect. We all know that there is a very strong placebo effect in psychiatric disorders, but it seems that there are very few studies that really try to quantify this placebo effect in a meaningful way, because it's actually challenging to compare placebo effect in the clinical trials. People usually use different clinical scales, so most of the time they're not directly comparable. And the other problem is that in placebo effect studies, most of the time people perform post-hoc analysis to compare the predictors for placebo effect. So which means that, in a certain condition, they try to find the predictors for placebo effect, and then they find the predictors of the placebo effect in another condition, and then they try to find the common predictors between these two conditions. The problem with that is they don't pull all the trials or all the studies together to consider the diagnosis difference between them, and also the potential interactions between the diagnosis types and the other predictors. So in this study, we try to quantify the placebo effect across major psychiatric disorders, which is MDD, bipolar disorder, and schizophrenia here. So we use the three measurements to compare the placebo effect. And we performed meta-analysis and meta-regression using the clinical trials data. So the details of all the clinical trials that we involved and the method, and also even the data we used, are all published because they are open access. It's free to everyone to get on scientific reports, and with the link below. So here we show in the first slides, in all the three measurements we use. So on the left we show it's actually the clinical trials. It's the clinical scales of the change of the clinical scales of placebo compared to that of intervention. So basically, we use the intervention as a reference point because different disorders, they may just have different population and different severity of the symptoms. So we find it's better to use the intervention as the reference point to compare the placebo effect rather than just directly use the clinical scales change of the placebo effect. And we also use the CGI severity score change of the placebo compared to the intervention. And in addition, because both of the CGI change, the ratio of the CGI change and the ratio of the clinical measurement change, they are actually use the intervention as the reference. So we also use the ratio of the decrease of the CGI from the baseline in the placebo conditions. So the third ratio was not depending on the intervention. So it's actually just compared to the baseline of the placebo condition. But surprisingly, over all the three measurements, you will see that they almost show the same quantification of placebo effect. So basically, all the mood disorders, including major depressive disorder, BD depression, BD depressive episode, and the BD manic episodes, they actually show a quite strong placebo effect. So compared to the intervention, you can actually reach above 80% of the intervention. So for the placebo effect, and compared to the baseline, you can actually reach over 30% of the change of the CGI score. And by the way, the CGI scores, they are actually directly comparable across all the conditions because they are basically the same score from the clinician about the impression of the severity, which is different from the clinical scale. But here you see, there are strong placebo effect for mood disorders, and the placebo effect in schizophrenia is also strong, but it's just much lower compared to mood disorders. So it's roughly usually like around 40 to 50% compared to the intervention, and usually it's about 15% compared to baseline. But here is probably the first time, as far as I know, that using like different measurements to compare the placebo effect across this three conditions. So if we combine BD and manic, just consider them as BD, bipolar disorder. And because of the original meta-analysis, it's actually just directly combine clinical trials with a large sample size and also small sample size. So we were afraid that the results were biased by some of the trials with very small sample size. So we performed the bootstrapping based on the sample size. We called it sample weighted bootstrapping. And we did this again, and we find that what we showed in the meta-analysis was also true using these techniques. So basically, across all the ratios, all the three ratios we use, all the mood disorders show very strong placebo effect, and the schizophrenia actually show much lower placebo effects. So we also actually perform two more studies on this data. We actually performed a meta-regression to include all the commonly thought predictors for placebo effect along with the diagnosis types. Here is just the major depressive disorder, bipolar disorder, and the schizophrenia. And we actually didn't find a very consistent predictors for placebo effect once we include the diagnosis types into the equation. So this was actually quite different from the previous studies, claim some of the predictors for placebo effect. And also I have to point out, there are actually very few studies that investigated the neurobiology of the placebo effect across the several disorders. So usually you probably will see some very nicely done neurobiological studies on a major depressive disorder, but not so much for other disorders, especially for to consider like several disorders at the same time within one single study. And we also performed a machine learning study. So basically the rationale was, if the three measurements of the placebo effect was so reliable, could we separate or distinguish the individual trials and what type of disorder they were about, using machine learning algorithms. So if we could do that, then it means that this placebo effect was so reliable, and we can even use it to identify the at the individual trial level about the trial, the disorders that the trial was involved with. We actually could do that, and the accuracy for that machine learning algorithm was actually over 80%. So for details of the predictors for placebo effect across these disorders, and also for the machine learning study, you can refer to my scientific report paper using the link below. So I would like to thank all the support and collaborators from these founders and organizations, and all my previous collaborators when I performed the ECT study, and also all my colleagues in the computational psychiatry group and Albert House. And we are always looking for young talents. Yeah, I'm very lucky to work in this very passionate and interdisciplinary and collaborative group. So thank you, everyone. That'll be all for my talk.
Is Dr. Chow there for questions? Is he available for questions? No? Okay. So we will move on to the last contribution, which is a live contribution online. And it's my great pleasure to introduce Dr. Jacob Cohen. Jacob is trained as a paramedic and has research and clinical frontline experience. He's worked in Israel and Canada. He's now considering whether to move to Denmark, I understand. And he is really interested in using cannabinoids and other drugs for the treatment of treatment-resistant post-traumatic stress disorder in first responders. He also presented the Canadian government on issues related to legalization and medical cannabis. So he's very much on the front line of treatment for PTSD and PTSI, and I look forward to his presentation. Over to you, Jacob. Thank you.
Thank you, everybody, for for listening, and thank you, Dr. Greenshaw, for the intro. So, like he said, I was a combat medic prior to starting university. I'm not a doctor yet. I'm starting my PhD in January, so I'm just a PhD candidate. But I did work as a consultant and still do in government and regulatory affairs. And I don't have any conflicts of interest to disclose because I work with all companies, but I was on the legalization side and lobbying the Canadian government to get Canada legalized and access expanded for veterans. So my focus, Dr. Zhang is actually my supervisor, so it's really interesting to be on a panel with him as an equal this time and not as a student. He already mentioned cannabinoids. We're going to focus more on what cannabinoids can do specifically for PTSD. So PTSD is obviously a mental illness, and it's the only illness where you need to be exposed to a trauma or to have this a threat, serious injury. Sexual violence is a big one, or you can witness one of those items and have PTSD. So what we see in PTSD is basically these symptoms is that there's a traumatic event. Patients re-experience the event through memories or flashbacks, try to avoid what caused the trauma in the first place. They have an inability to function for over 30 days, and then they have increased arousal because of that. So not too much is known in depth, but what we know pretty much in depth from PTSD the most is that it affects certain centers that I'll talk about, such as prefrontal cortex, which we know is important for decision making, the amygdala, which is our conditioned fear and associated learning, and the hippocampus, which is responsible for memory. And then another important one to mention is the thalamus, which regulates body temperature. So we see all these key brain areas, like fear, memory, decisions, are affected severely in PTSD. So another key system to mention in PTSD, why there's a brain and body dysregulation, is there's an overactivation of, it's called the HPA, so the hypothalamic, pituitary, and adrenal axis. So this system works together, as you can see from this diagram, to basically, once there's a stressor or there's a stimulating event, it activates our hypothalamus, secrete corticotropic releasing hormone, or pituitary, release actual corticotropin, send that to the adrenal cortex, which can secrete cortisol. Also, it can secrete norepinephrine than just straight epinephrine if we need to activate our flight response. But cortisol has really profound effects also on the hippocampus and the amygdala. So in the hippocampus, actually an overuse or overproduction can lead to an atrophy and an increase in the size of the amygdala. So you have worse memory, and you have an overly conditioned fear response because you're remaining too much in the elevated state, and cortisol is continuously being released to accommodate that. So how does endocannabinoids in the system work? So as Dr. Zhang mentioned, we actually have receptors for cannabinoids endogenous to the human body. CB1 is, as we can see here, mostly concentrated in the brain, and then there's a huge connection in the stomach, and then there's some more throughout the periphery. And CB2 is concentrated mostly in the periphery, and then there's also some in the brain. Then this explains why you can see on the diagram there's a huge logical explanation for the brain-gut connection. So your nutrition affects your mood, obviously, and we can see that back up through here. Most common cannabinoids are anandamide, which is very similar in structure to THC, broken down by FAAH. It's a partial agonist at CB1 receptors and has a full agonistic activity at the TRPV1 receptor, which is responsible for pain. Then there's 2-AG, which is a CB1 and CB2 agonist, and it really resembles CBD, which mostly is responsible for immune functions, like modulating cell migration and cytokine flow and production, and can affect glial cell migration, suppressing it in injuries especially to the brain. That mechanism is unclear. And as you can see in this diagram on the left, when there's a stress or a trauma, the inflammatory cytokines, especially IL-1 and IL-6, increase in production. And this goes and specifically affects brain areas mentioned before, like the frontal cortex, MPFC, the medial prefrontal cortex, pituitary to secrete cortisol to the adrenal glands, amygdala, and the hippocampus. And then the adrenals are also responsible, and the cortisol is directly responsible and directly modulates certain cytokines and certain immune cells, such as macrophages and T cells, which we know are also hugely responsible for cytokine responses, especially IL-1 and 6. And tumor necrosis factor, TNF, is another big one. So we'll get into specifically what is THC. So THC is a partial agonist at the CB1 and CB2 receptor. It's really close in structure to anandamide, our endogenous cannabinoid receptor. But it crosses the blood-brain barrier a lot more readily than the other compounds, which explains why it's so psychoactive. The only issue with THC use is that if you use it frequently, it can actually negatively affect your cognition by reducing your gray matter. And it affects memory and cognition long-term. There's also an issue with synthetic cannabinoids. Synthetic products such as spice can actually be linked to acute psychosis episodes. And then just some pharmacology. Within 5 days, it's mostly eliminated in the urine. But you can detect it in your hair and sweat up to 3 months after using it. Then the only real contraindications of using it as a medicine would be using it while performing heavy tasks or anything involving machinery and use during pregnancy. The daily high use could be an issue because we don't really know the sweet spot, and because there are endogenous receptors, everybody's body is different. So hitting that sweet spot for everybody may be vastly different person to person. So CBD, like I mentioned, very close in structure to 2-AG, has little affinity for CB1 and CB2 receptors, but it's been shown in animal and human models to have anxiolytic effects by acting at the serotonin, norepinephrine, and acetylcholine receptors. also acts at the TRPV1 receptor to modulate pain, the glutamine receptors as well. And it has a huge effect on immune responses and in injury. So just quickly acting on the COX-2, IL-1, and FAH pathway, modulating DNF to reduce pain and inflammation in an injury. Then it seems to prevent glial cell hyperactivation in brain injury. That mechanism is still unclear and being worked out. There are huge sex differences, both with PTSD and in cannabinoid receptors. Males and females also show huge differences in terms of cytokine responses. There's also just at baseline. Our study showed a tenfold difference at the baseline. We saw a difference in female rats, between female and male rats. And then also at the base level, there's different sizes and structures across key brain areas, like the amygdala in men is larger, NSD is twice as large in men, and the hippocampus is a little bit smaller in men than in women in humans. So the summary of PTSD mechanisms, we can see this wheel. PTSD can lead to poor sleep, which enhances your negative effects on your cognition, which if you have poor cognition, you're going to have impulsive behaviors and more arousal, which is going to worsen your adrenal dysfunction because you're not sleeping, your cortisol and your other hormones are going to be thrown off, which will lead to more inflammation, and you'll feel more pain, which in turn can make you sleep better. And then this wheel will just keep going. It's a very vicious wheel to get out of once it's begun. So in summary for cannabis, all targets of CBD and THC where they can act have shown the ability in human and animal studies to reduce pain and inflammation through cytokines mainly. THC can help you fall asleep. Use actually keeps patients in REM sleep for shorter periods. So they're sleeping, but they're having a poor sleep. Also, CBD might promote REM, but it needs moderate to very high doses. And again, because it's endogenous and everybody's different, it's really hard to specifically pinpoint a dose and give a proper guideline when we're trying to apply it to the public. And both of them, again, very dose dependent, very person dependent, and have anxiolytic effects, but it can also go the other way depending on the dose. So for the psychotherapy options, CBT or cognitive behavioral therapy is agreed upon pretty much by everybody to be the gold standard. Trauma, there's also large agreement that trauma-focused interventions are the best. However, there's a debate, especially within the patient community, about the pharmacological interventions, especially the additional pharma. There's most also agree that SSRIs are should be the first line treatment, should be continued regardless of if somebody's using cannabis or not. Another interesting one is the prolonged exposure and movement desensitization and reprocessing, or EMDR, and specifically trauma-focused CBT therapies, which actually intentionally confront patient's trauma and try and change the response, as well as the negative thoughts with the memories associated with that trauma, so they can re-experience and have it and actually confront, so they don't avoid, they're able to positively experience some aspects or think about the trauma they experienced again. So as we can see, it's just some pictures. On the left is virtual reality, a soldier's going back through a field of whatever he may have experienced prior. And then in EMDR, basically your eyes just follow the blue light. And then when you talk through, you confront your trauma, and these lights train your eyes to slow down and basically make your body relax while you're confronting the trauma. So these two principles, the main targets for cannabis and other drugs, is fear extinction, which can be summed up where if you have a traumatic experience, so let's say a dog attacks you, over time, it shouldn't matter, and you should go back and just see a dog for what it is, which is acute drug. In memory reconsolidation, what we're trying to do is, let's say a dog attacks you, you go back and you pull apart that memory, you maybe change it to think about, oh, one time it was just a puppy, maybe it's nice, maybe something. You forget about that it attacked you, you remember the nice memories, and you can eventually go back to seeing it for the nice dog that it is. So like the first speaker mentioned, there's many drugs that target fear extinction and memory reconsolidation. One really notable one is ketamine. Microdoses of ketamine can actually allow patients to dissociate, allow faster reconsolidation of traumatic memories. MDMA and psilocybin, which are now being hugely explored in clinical trials. Psilocybin has also just been allowed in Canada for compassionate use for certain disorders, especially cancer. It allows patients to be more relaxed during these therapy sessions. They can actually dive deeper into exposure therapies and quickly enhance the fear extinction. And then again, psilocybin is doing the same thing as MDMA. It's promoting a huge release of serotonin and dopamine, leaving patients in a relaxed or euphoric state even after confronting really intense trauma. So for the risks, cannabis has very low risks. There's some mild side effects and an addiction potential. There still hasn't been a reported death from overuse of cannabis. With MDMA, the risks are moderate. There's a lower addiction potential than cannabis, but side effects have included brain and kidney damage, and you can die from overuse. Ketamine is very high risk. Moderate to high doses, it can cause sedation, immobility, and at high doses, patients have compared it to a near-death experience, and when combined with alcohol, it can be fatal. So what do we know for sure? That cannabis can give an acute benefit mainly for sleep and is well tolerated by most people. CBD and delta-9 THC can be equally beneficial for PTSD patients and focus on targeting the extinction and memory reconsolidation paths. The only issue is trials to date have relied on smoked cannabis. With the advent of cannabis legalization in certain countries and technology, we now have better tools, and then we should be really using oils because they're more reliable for dosing, more reliable batch to batch, and it's obviously significantly less harmful to swallow some oil or vape a pen than it is to smoke it or mix it with tobacco. So where do we go? So the only way to go with this and to prove something with certainty is to do blinded randomized clinical trials. Sex differences are still highly underexplored in cannabis and in PTSD, and that's going to need to be figured out because although it does primarily affect men, there still is a huge population being underserved and underrepresented, which is women. We also need global populations and comparisons with PTSD and with cannabis because cannabis differs country to country, and then also PTSD differs country to country. Current studies have mostly focused on North America and Western Europe, mostly the UK. We also need removal of government red tape and bias because cannabis, as Dr. Zhang showed, has been a medicine for thousands of years. It was only recently that we had issues, but with the advent of legalization, we've moved more in the last 3 years in Canada. We have in the last 60 after it was legalized. Also, studies should somewhat reflect what the population interests are. This is just a Google graph I took recently where you can see THC is in the blue, delta-9 THC. Psilocybin is in the red, and there's currently large clinical trials. Another phytocannabinoid is delta-8 THC, which is similar to delta-9 THC. It's just less potent and might have less harmful side effects. Is also being equally searched to psilocybin, but there are currently no trials delta-8 THC, which may give a benefit. So the public interest should also show it because people will, especially now in certain jurisdictions, are able to find unregulated delta 8 THC products. It's just easier for everybody if you can make a nice and safe regulated product, as we're seeing and data from jurisdictions where it's legal showing their benefits when there's proper regulation and safety regulation, so people are making home concoction. And if there's any questions, I'm happy to take them. Thank you for your time.
Thank you very much for a very clear talk, Jacob. That's very good. So the floor is open for up to 2 questions. Anybody have a question for Jacob? Maybe I'll start. Jacob, you talked about THC for trauma-informed care, looking at drug-augmented treatment. Psilocybin is becoming very popular. Do you have any idea of the relative effectiveness in that context of those 2 very different drugs?
Sorry?
Looking at augmentation of psychotherapy or 3-MDR with drug treatment, thinking about the possibility of using psilocybin or cannabis constituent, what do you think the relative benefit of those 2 approaches will be?
So I think for the benefit, and we're kind of seeing that with the psilocybin trials, is that patients are more relaxed and are able to kind of delve into that trauma a little more easily, or are able to come out of the session less traumatized and maybe forget a little bit faster and not dwell as much. But I think it might just, even if it disinhibits them a little bit, they might be able to break further into that therapy session and go deeper, where somebody that's sober may not be able to.
Okay, thank you. Any other questions for Dr. Kuhn? One question back, Tony White. Just taking the microphone.
Hello, thank you for your talk. I have a question. Do you know if there's any studies looking at people who use chronic cannabis have less incidence of PTSD?
So they actually just released a study by a very prominent cannabis researcher, and they actually found that over a period of 3 years, there wasn't any real difference in the PTSD benefit, except that patients were able to sleep better and had a little bit less symptoms, but it wasn't statistically significant. So in short, it does give a benefit, and it does get that acute benefit, so it may help them a little bit. It doesn't make it worse. So it's probably best just to use it to get over the acute portion, or help you sleep so you can at least do that. It's definitely not like a permanent solution.
I was actually wondering about people who use it and then have a traumatic effect.
Oh, honestly, I'm not sure, but that would be really cool. I'd love to look into that personally if anybody on this panel is interested.
Thanks.
Thank you very much, Jacob. We're out of time now. I'd like to thank all of the speakers. It's been really good because we've kept on time, even though some have been virtual and some have been really in the room. Jacob, thank you very much for your participation. Any other speakers who are online, thank you very much. And thank you very much to Declan McLaughlin for his first presentation. It's very good. So you could join me in a round of applause for all of the speakers, and we'll conclude the session. Thank you. Have a good day, Jacob. Thank you very much.
Yeah, you too.